Good morning, everyone. It's my pleasure to introduce Dr. Gary Volkell. He's a highly respected neurologist with extensive experience in movement disorders, particularly Parkinson's disease. Not only that, he is also a close personal friend of mine. Dr. Volkell completed both his residency and his fellowship at Albany Medical Center, where he specialized in neurology with a focus on Parkinson's research and patient care. He has a particular interest in guiding surgical intervention for treatment of PD, tremor, and dystonia. He now works at MedStar Franklin Square Medical Center in Baltimore, Maryland, where he's the director of movement disorders. Dr. Volkell also has an academic appointment at Georgetown University Hospital. Today, he'll be sharing his latest insights and advancements in the management and treatment of atypical Parkinsonism. Please join me in welcoming Dr. Volkell for today's Grand Rounds.
Thanks, Dr. Wyatt. Hopefully everyone can hear me okay, but let me know if you can't through the chat. Like Dr. Wyatt said, I'm Gary Volkell. It's very nice to meet you all virtually. And today we were going to be talking about atypical Parkinsonism. Let me make sure my slides. Okay. There's only a few videos, so hopefully those work okay, but let me know if they don't. We could always send them out later with the slides. I don't have any disclosures. And here's my outline for the talk today. Just because we're going to be talking about atypical Parkinsonism, which is a little bit more complicated, I'm going to start off with a brief review of Parkinson's disease and what Parkinsonism is. That way, when we talk about what atypical Parkinsonism is, we have something to compare it to. We have the 4 types of atypical Parkinsonism that we're going to talk about listed there as well, but we'll go into more detail. And before we get started, if anything happens or you have a question, please feel free to butt in or leave a message in the chat. I'm happy to take a pause, or we can do questions at the end if that's easier too. But just to start off with a basic review of Parkinson's disease, reviewing the anatomy, we need to talk a little bit about dopamine. So dopamine is a hormone or a neurotransmitter. It's a chemical, and it's used to pass along signals and messages in the brain and throughout the rest of the nervous system. It plays a role in a number of different things like motivation and reward, pleasure. Most people think of dopamine and serotonin as the chemicals we need to be happy, but it has other functions as well. And our main focus is going to be on how the role it plays in movement specifically. Dopamine can be found all over throughout our nervous system, but it's primarily produced over here in the substantia nigra. I hope you can see my cursor moving, but it's this on this sagittal cut, this mid-sagittal cut of the brain. You can see the midbrain up here, and this area that's colored in red is the substantia nigra. Substantia nigra translates something to black substance because dopamine is part of the melanin pathway, and it actually turns up black when we are looking at it under a slide or even on gross pathology, and I'll show you a picture of that. The way dopamine is used, it starts off in the substantia nigra here. Again, we have a mid-sagittal view of the brain, and it's kind of in magenta here. The dopamine goes out to the other basal ganglia, which are some nuclei in the brain. They're also in magenta, and they're labeled along here. And then together, these parts of the brain help us have normal movements. Once the dopamine has been used up, it gets broken up and recycled. It's very precious, so we don't want to waste, so we reuse it again. So what happens in Parkinson's disease? We're going to talk a little bit more about this abnormal protein called alpha-synuclein in a few slides. But this abnormal protein, or alpha-synuclein, it becomes phosphorylated, becomes abnormal. It can't really fit where it needs to go. Deposits all over the body, it accumulates all over the body, and it can start to break things. So specifically when it deposits in the substantia nigra, it injures and kills those brain cells, and then those people have less dopamine. When they have less dopamine, they start to experience the symptoms of Parkinson's disease. And you can see here to the right, in the left part of this picture, we have a slice, an axial cut of the midbrain. And you can see these kind of black stripes here. That would be the substantia nigra, again, like black substance. And this would be somebody without some kind of Parkinsonian condition. versus on the right here where you can kind of still see it, but it's kind of like a faded gray. And this would be substantia nigra that's been affected by some kind of what we would call neurodegenerative form of Parkinsonism, whether it's Parkinson's disease or maybe one of these atypical Parkinsonisms that we're talking about. So you can even see on a gross pathology that it looks quite different from those loss of brain cells. Let's talk a little bit about those symptoms. So there's two categories of symptoms for Parkinson's disease. There are motor symptoms, which affect the way we move, and then non-motor symptoms, which affect everything else, which is pretty vague, but we'll talk about those briefly. So the motor symptoms of Parkinson's disease are these are what we call the cardinal symptoms of Parkinson's disease. There is bradykinesia, which is a slowness of movement, rigidity, which is stiffness of muscles, tremor, and then postural or gait instability or impairment, so a change in the way people walk and keep balance. All four of these together are the main motor symptoms, and we sometimes refer to them as Parkinsonism. So this does not make a diagnosis. Kind of like with a lot of things in medicine, sometimes we describe the name of symptoms, but it doesn't necessarily tell you what the cause of the symptoms is. So, for example, a fever may be caused by an infection, but it doesn't tell you what the infection is, if it's a bacterium or a virus or something else. When we say Parkinsonism, it's not actually a diagnosis. We have to figure out what's causing the Parkinsonism, with the most common one being Parkinson's disease. And Parkinsonism, again, is just another way to say motor symptoms of Parkinson's disease. Bradykinesia is in a different color and bolded because when we're diagnosing Parkinson's disease, a patient needs to have bradykinesia and at least one of these three other things before we can comfortably make the diagnosis. And I'm harping on the fact that we're talking about Parkinsonism because we're going to see these things in certain other diseases as well that may not be Parkinson's disease, but may still exhibit these symptoms. Another example of when it may not be a disease is there are certain medicines that you may be familiar with, some of the antipsychotic medications or antiemetic medications, which can cause Parkinsonism, but it doesn't mean the person has Parkinson's disease. Again, it's just a description of what they look like. Some of those non-motor symptoms, again, these are the ones that affect everything else. This is a small list, but I broke it down into these categories. So there's neuropsychiatric symptoms, things like depression, anxiety, apathy, right? We talked a little bit about how dopamine plays a role in mood. So it makes sense that if you're losing it, you may have a change in mood. It can lead to impulsivity and psychosis as well, including things like hallucinations, illusions, delusions, things like that. There's neurocognitive changes. It can go on to cause something called a Parkinson's disease dementia, different from other types of dementia. Dysautonomia, which we'll talk about with some of these other atypical Parkinsonisms, but orthostatic hypotension, constipation, erectile dysfunction, drooling, sexual dysfunction, altered senses. Some of these people will develop anosmia, so a loss of the sense of smell, or dysgeusia, a change in taste, even years, sometimes decades before the motor symptoms of Parkinson's disease. And then other sleep disorders, with probably the most important one that we'll be talking about today, which is called REM sleep behavior disorder. And if you see me abbreviate RBD, that's what I'm talking about. And that's when people have these really vivid or lifelike dreams all while they're asleep. They're usually action-packed, violent, and they will start to act out their dreams in their sleep because for whatever reason, while they're in their REM sleep, their body is not paralyzed. So they will act them out. They'll punch, they'll kick, they'll scream, and that can be dangerous for themselves because they could fall out of bed or hurt themselves, or a bed partner. So somebody who they're in bed with, they could accidentally punch them, for example, and hurt them. How do we diagnose Parkinson's disease? Well, we do that clinically, typically, where somebody would tell the provider what's been going on. They'll do their physical exam, and then usually we can make the diagnosis right then and there. Obviously, there are some tricky cases, like I was saying before. Maybe somebody has an atypical Parkinsonism, or they're taking medicines that can cause Parkinsonism, like something like risperidone or aripiprazole, right, Abilify. When we're a little bit confused or there's a lot of things going on, there's a few special tests we can use. One is called a DAT scan over here. The DA stands for dopamine, the T is for transporter. We use a radioisotope called ioflupine. It binds to the presynaptic dopamine neurons. The transporter is actually a protein on those neurons. And in somebody without Parkinson's or or an atypical Parkinsonism, it looks kind of like this. They kind of look like robust commas here, like the punctuation mark, versus somebody with some form of neurodegenerative Parkinsonism. You can see there's a loss of those brain cells that have that dopamine transporter because they've died, probably from alpha-synuclein if this is Parkinson's disease. And you can see they're actually asymmetric here, right? It's a little bit healthier on the right, less healthy on the left. So since we're looking at the person, everything's opposite. So right is on the left is on the right. And this is somebody with some form of neurodegenerative Parkinsonism. It doesn't tell you which one they have, if this is Parkinson's disease or an atypical Parkinsonism. It just lets you know something's wrong, and then clinically you have to figure out what it is. Another thing, there's I say newer, but probably about 3 to 4, 5 years old now. We've been doing these special skin biopsies. It's very similar to a skin biopsy you would do to look for like peripheral neuropathy or amyloid. This can look for that abnormal protein called alpha-synuclein. The one that I'm familiar with is called a SYN1 test, so SYN, and then the number 1, ONE. And it's just 3 punch biopsies on the skin, right above the ankle, right above the knee, and then right along the back. And we send those tissue samples off, a lab processes them and looks for things like alpha-synuclein. Okay. Treating, we'll kind of breeze through this so we can move on to our atypical Parkinsonism, but the standard of care is usually carbidopa-levodopa. So because in Parkinson's disease, people are losing dopamine, we give them medicine that turns back into dopamine. So levodopa is a precursor to dopamine. It can cross the blood-brain barrier, and carbidopa is like a suit of armor. It protects the levodopa so it gets there safely. That's how I think of it. When it reaches there, the person gets a little boost of dopamine, and then their motor symptoms may get a little bit closer to normal. It's never perfect. There's other oral therapies too, things like dopamine agonists. So aside from carbidopa-levodopa, we can give a medicine like ropinirole or pramipexole, which binds to dopamine receptors and tricks your brain and body into thinking it has dopamine, even though it doesn't. There are certain rescue therapies. The only 2 on the market right now is an aerosolized carbidopa-levodopa, which you put a capsule in a little special kind of like a spring-loaded device that looks like a little handheld oval, and you inhale it almost like an inhaler, and you absorb the dopamine that way. So it can help if you have a sudden episode of your medicine's not working. It can give you a little boost to get you to your next dose. And there's also an injectable version called apomorphine, which has nothing to do with morphine, totally different. There are certain surgical infusion therapies, like there's one that goes directly into the gut, and there's newer ones which are subcutaneous. And then there's also some neurosurgical interventions, things like deep brain stimulation, or DBS for short, as well as a newer modality called MR-guided focused ultrasound, or FUS for short. I mentioned these here, but unfortunately, those neurosurgical ones I just mentioned, the DBS and the FUS, are not going to be available to anyone with atypical Parkinsonism. Okay, so we'll move on to atypical Parkinsonism. I've included this picture, the classic illusion of, is this an old woman or is it a young woman? And the answer is it's sort of both, or whatever you're seeing in the moment. I included that here because atypical Parkinsonism is something that looks like Parkinson's disease, but might actually be something different. And it can be very difficult to tell the difference between Parkinson's disease versus an atypical Parkinsonism, and sometimes an atypical Parkinsonism from another atypical Parkinsonism. So that's why I've included that picture. Also, it's fun to look at. Anyway, but let's talk a little bit about it. And when I talk about Parkinson's disease and the atypical Parkinsonisms, I like to talk about bad proteins. So we had a kind of a brief introduction to alpha-synuclein, but the other one we'll be talking about is called tau. So if you see any of these abbreviations, that's what I'm talking about. And we're going to divide them into those 2 categories. So that's typically how I think about the pathology, because some of these diseases will have alpha-synuclein as the bad protein, and we call them alpha-synucleinopathies. And some will have tau as the bad protein, so we call them tauopathies. And the reason I've divided them this way is when you start to see the symptoms, you'll see some symptoms are more reflective of an alpha-synucleinopathy, and some are more reflective of a tauopathy. The ones that we're going to be talking about today are in green. I've included some of these other smaller ones, which have similar proteins and have similar overlap with what we're talking about, but it won't be the focus of this. But when we talk about alpha-synuclein, the first one we talk about is Parkinson's disease or idiopathic Parkinson's disease, which we kind of just touched upon. There's dementia with Lewy bodies and multiple system atrophy. And this is a shout out to Dr. Wyant, who actually gave me this acronym in residency as a nice little reminder. So if you spell out the word POM, you have the alpha for alpha-synucleinopathy represents the A, but P is for Parkinson's disease, L is for dementia with Lewy bodies, and M is for multiple system atrophy. So it's a nice reminder technique, a little mnemonic. Versus tau, which would be everything that wasn't included there, which is really what we'll be focusing on: progressive supranuclear palsy and corticobasal degeneration. Because each of these is a mouthful, and you'll get tired of hearing me say progressive supranuclear palsy a million times, I will probably just be referring it to as PSP, but if that gets tricky, I will try to say them all out again. Interestingly, there are other diseases that carry some of these proteins as well. So tau we know is in a lot of things. Alzheimer's dementia is one of them. Also frontotemporal dementia. And frontotemporal dementia does have some overlapping with the Parkinsonisms, the Tauopathy Parkinsonism. So we're not going to be talking about it, but I included it here because they're all kind of related to each other. But we'll focus first on alpha-synucleinopathies. So I've included the risk factors here. So going from the top down, it goes from less risky to more risky. So of having an alpha-synucleinopathy. And same with symptoms and signs. It starts with the least risky to the most risky or the most suspicious of alpha-synucleinopathy. And again, you'll see at the bottom, the thing that is most likely to be specific for an alpha-synucleinopathy is that REM sleep behavior disorder. But you'll notice that some of the things that overlap with Parkinson's disease, right, and alpha-synucleinopathy are that loss of smell, depression and anxiety, constipation, orthostatic hypotension, right? These are the things that we expect to find in an alpha-synucleinopathy. We're going to talk about our first one, which is dementia with Lewy bodies, or DLB for short. Now, I'm sure many people have heard of dementia with Lewy bodies, but may have also heard it as Lewy body dementia. So then I have to ask the question, what's the difference? Are they the same thing? And the answer is, of course not. We're neurologists. We're pedantic about everything. So there has to be very slight differences. That way we can make fun of people who don't know the difference. So with Lewy body disorders, more broadly speaking, that is any kind of disease that you see Lewy bodies under the microscope on pathology, on autopsy, right? So this is like the picture that's included in, I think, every textbook of a Lewy body. Here it is, the histopathology. There are several diseases that have Lewy bodies in them. Parkinson's disease is one of them, and dementia with Lewy bodies is the other. I've included that. Sometimes we separate out Parkinson's disease, mild cognitive impairment, Parkinson's disease, dementia. That's all part of the Parkinson's disease spectrum. So when we talk about Lewy body dementia, it's actually an umbrella term that includes any dementia caused by a disease with Lewy bodies associated with it. There's two that we've talked about, which are Parkinson's disease and dementia with Lewy bodies. So Parkinson's disease dementia is a type of Lewy body dementia. Dementia with Lewy bodies is a type of Lewy body dementia. So when we're talking about the disease, the atypical Parkinsonism, we're talking about dementia with Lewy bodies. Okay, it is separate from idiopathic Parkinson's disease. That said, they are very similar. And in fact, when I'm talking to my patients, I talk about Parkinson's disease and dementia with Lewy bodies as sister diseases because they are very closely related. And oftentimes it can be really hard as a provider telling the patient, you definitely have Parkinson's disease or you definitely have dementia with Lewy bodies, because it requires the patient or their caregivers to give us very accurate timelines of when certain symptoms started. Because of that, sometimes I say you either have this or that, but we treat them very similarly, and the process is very similar. And for that reason, I never want to confuse people because my least favorite thing is after I say, I think that you have dementia with Lewy bodies, I'm not totally sure, but it's very similar to Parkinson's disease. We're going to treat them the same and everything will work out kind of the same. The one thing I hate to hear is the doctors have no idea what's wrong with me. They're not even sure what my diagnosis is. So we've all been in that position probably, but this is one of the times where I understand why a patient would say that. So I try to explain that they're very similar and that it's okay to not know the exact diagnosis because they get treated the same way. Again, timing is the key. And the way that I think about this is in Parkinson's disease, like I said, people will usually go on to develop some kind of dementia, and they can develop things like hallucinations and things like that. Often that happens several years into the diagnosis of Parkinson's disease, so several years after they've developed motor symptoms, that Parkinsonism that we were talking about. The big difference is that with dementia with Lewy bodies, the motor symptoms start, and within 1 year of the motor symptoms starting, they also develop cognitive changes like dementia and things like visual hallucinations, usually seeing small animals or children that aren't really there. Okay. And really that's what it comes down to. It's whether or not you have those dementing or hallucinatory changes that happen within 1 year of motor symptoms starting. That's it. And if the patient is already confused or their caretaker or loved one does not have an exact timeline, we may never know. So we sometimes have to do our best guess. But again, treated very similarly to Parkinson's disease, with, again, the exception, which will be true for all of these, we are not offering those neurosurgical therapies. We're managing motor symptoms pretty much the same way. When people are having these hallucinations early, we address them with antipsychotics. We try to steer away from the ones that could worsen those motor symptoms and cause Parkinsonism on their own. So we're usually talking about things like quetiapine, which goes by the brand name Seroquel, or one of the newer ones, which is called pimavanserin, which goes by the brand name Nuplazid, and sometimes things like clozapine, which is Clozaril. Sometimes we use things like donepezil or rivastigmine to help with dementia. Again, not perfect, but it can help a little bit. And then symptomatic management for everything else: constipation, for difficulty swallowing, for sleeping problems. We're using sleep aids. We're same kind of thing we do for anyone with those things. We're using laxatives or stool softeners for constipation. And then, of course, and this is going to be true for every disease we talk about today, physical therapy, occupational therapy, and speech therapy to help with movements, swallowing if they're having difficulty swallowing, speech if they're having difficulty talking. Okay, it's a mouthful. Let's talk about multiple system atrophy. So this is our other alpha-synucleinopathy we're talking about, and you're going to see it's going to share a lot of similar things to Parkinson's disease and dementia with Lewy bodies. It's had a lot of different names over the years, with my favorite probably being olivopontocerebellar atrophy, because it tells you every single part of the brain that is shrinking from this disease. So I love that one. But multiple system atrophy is the preferred now. Like we said, it's one of our alpha-synucleinopathies. Includes these cytoplasmic inclusions in the brain cells or glial cells. So things like in the oligodendrocytes, which is something called a glial cytoplasmic inclusion. And that kind of scarring, that gliosis and axonal degeneration distinguishes multiple system atrophy from Parkinson's disease. Obviously not helpful in a living human. These are things that we only find out afterwards. And sometimes we are surprised. We think that it is Parkinson's disease, but then it turns out to be MSA, or we think it's MSA and it turns out to be Parkinson's disease. And we don't get our true answer until after the person is deceased. Because it's an alpha-synucleinopathy, Lewy bodies can be present. Life expectancy after symptom onset, not very long, and that's going to be true for a lot of these atypical Parkinsonisms. There's two subtypes of MSA. There's the one where the symptoms are more consistent with a Parkinsonism, where they look a little bit more like they could have Parkinson's disease, versus one where it looks a little bit more like they have a cerebellar ataxia, where as a reminder for ataxia, that's a kind of a disorganized motor output. So clumsiness, slurred speech, problems with eye movements, falls, right? Think of a drunk person. That's a classic example of somebody with a cerebellar ataxia, temporary in that case, hopefully. Similar sorts of prodromal symptoms like we saw in Parkinson's disease. We have REM sleep behavior disorder. Again, that's a staple of alpha-synucleinopathies. If somebody has REM sleep behavior disorder, it almost completely excludes a tauopathy. So that's a nice way to organize your thinking about it. But though when I think about MSA, just like for dementia with Lewy bodies, I'm usually thinking about hallucinations and dementia happening really early as the thing that distinguishes it from Parkinson's disease. With multiple system atrophy, I'm thinking about autonomic failure. So this is a problem with the autonomic nervous system. So really bad orthostatic hypotension, loss of sweating, so dry, flaky skin, bladder dysfunction, erectile dysfunction, constipation. These are all things I said could be in Parkinson's disease, but with MSA, it's like so much worse, so fast, so bad, totally debilitating very early, as opposed to Parkinson's disease, where usually it's a little bit of a slower process. So looking at these distinguishing symptoms, I know this is a big list. I won't focus on all the things here, but we'll point out some of these things. You can have kind of some funny changes in the person that are more suggestive of MSA. So there's this thing called a striatal toe, which is over here in the person's left foot here, which is this extensor plantar response where the toes don't fan. It's really just the hallux, the big toe going up. You have more of a gait instability with falls and get put in a wheelchair a little bit earlier than what you'd expect in somebody with Parkinson's disease. You can get a change in the speech, which can be considered a dysarthria. You can get difficulty swallowing, which ends up being a really big problem in people with MSA. Kind of linked with stridor here, which is that high-pitched abnormal breathing sound that probably we haven't thought about since pediatrics. But the airway can get narrower, and this usually ends up being the cause of somebody's demise in MSA, so it's important that gets evaluated. They can get cold hands and feet, so temperature dysregulation, right? More dysautonomia. You can see those purple hands here. They can get these myoclonic jerks. You can get these slow tremors, a little bit different from Parkinson's disease. And then they can develop dystonia, which is a twisting or pulling of the muscles. And when that happens in the neck, we call that cervical dystonia. And classically, again, nobody has to follow the rules, but classically we see that as anterocollis, which is a pulling forward of the head and neck, which you see up in this picture on the right. So you can see a patient and a drawing of it here. It can be quite painful, so sometimes we try to address that pain. And yeah, okay. Just to touch upon orthostatic hypotension. I know people are familiar with this already, so I won't dwell too much on it, but I consider it a hallmark of most people with multiple system atrophy. There aren't too many people I've taken care of with multiple system atrophy who do not have this, although it's possible. I won't go over to the details. I'm sure everyone knows how to measure this. But when I'm talking about trying to address it, we do usually lifestyle modifications first. So drinking plenty of water. I try to have people front load their water intake. So drinking, a cup or two in the morning with breakfast, a cup or two in the afternoon, and maybe not so much at night so they're not peeing the whole night because then they don't sleep well. High salt diet. I feel like I'm the only doctor who ever tells somebody to add salt to their diet, and it's just for this case. With things like compression stockings and abdominal binders help return blood flow to the heart, boost blood pressure. The abdominal binder is actually probably better than the compression stockings. We have all those splanchnic vessels, which retain a lot of fluid, so that's a really good one to stress. And then elevating the head of the bed so they're not lying perfectly flat. Sometimes we have to rely on whoever's prescribing antihypertensive medications. They may have to reduce or stop that if it's safe to. And if needed, we sometimes add medicines that increase blood pressure. The staple is usually midodrine or fludrocortisone. Sometimes we'll use droxidopa, which goes by the brand name Northera. I don't know if that works, but yeah, midodrine and fludrocortisone do help with that. So those are things we think about. And one of the things I didn't include here is sometimes the carbidopa-levodopa has to be reduced because just like in Parkinson's disease and in multiple system atrophy, they can cause orthostatic hypotension. The disease itself does it. We sometimes try to treat these people with carbidopa-levodopa to see if it helps some of the motor symptoms. Unfortunately, the medicine actually can worsen orthostatic blood pressure. So sometimes it means reducing that and compromising, and maybe the motor symptoms get worse. So it's a little bit of walking the tightrope and a discussion with the patient to see what they would rather have. We'll take a look at some neuroimaging here. Sometimes you can see here on T2, you can kind of see this dark, so hyper intense rim border of the putamen here, right? The putamen is this kind of ovular shape, sort of here. But more classically, what you probably heard of is this sign that we see with shrinking, so atrophy of the pons. So this is an axial cut here, and you can see the pons right here, and it's kind of got this plus sign, and it's supposed to look like a hot cross bun, which is over here. So seeing that could be very suggestive of pontine atrophy. You'll also see shrinkage of the middle cerebellar peduncles, which come out from around here as well. And then for a mid-sagittal look, you can see that the pons, which is normally much more plump, is significantly shrunken here. And the cerebellum, which should normally fill this space a little bit more, is pretty shrunken as well. And in fact, when we talk about cerebellar ataxia in an adult, the most common cause would be multiple system atrophy as opposed to some of the rarer types of cerebellar ataxia. Okay, so treatment, there isn't a whole lot we can offer for most of these, but again, we could try carbidopa-levodopa therapy for patients with a more Parkinsonian predominant multiple system atrophy to see if it helps with their motor symptoms. Again, like I said before, it can worsen their orthostasis. Physical therapy and occupational therapy to help with ambulation, mobility, but like I was saying earlier, with a life expectancy of 6 to 10 years, a lot of these people end up in a wheelchair before they die. So oftentimes they'll progress to a wheelchair use. Speech therapy to help with, they kind of get that funny voice. They can get that stridor as well. For somebody who has the myoclonic jerks, they may benefit from something like levetiracetam, which not because they have seizures, but just to help reducing those jerks. For that neck pain, we can try things like baclofen or gabapentin, or sometimes botulinum toxin injections to help with that cervical dystonia, that neck pain of the twisting and pulling of the muscles. For all anxiety, depression, things like SSRIs, escitalopram, choose your medicine to help with mood can be of benefit. And then, like I said before, stridor can lead to somebody's demise. So having them see a sleep specialist, maybe even trying something like a PAP, like a CPAP or something to help at night could be beneficial. Never bad to have palliative care on somebody with a terminal illness like this. So I'm going to move away from the alpha-synucleinopathies, and we're going to talk about that abnormal protein called tau. So it's not as much, I feel like, known about these tauopathies. They're a little bit more complicated, but also kind of interesting. The risk factors for something like I can't speak anymore. Progressive supranuclear palsy are things like older age, a lower educational level, and duration to things like well water and industrial waste, versus for corticobasal degeneration would just be age. So you see the risk factors are not as well known. And I do love this figure here. So it actually has a bunch of the abnormal proteins, so the two we're talking about, so tau and alpha-synuclein, but you can see there's a few others. You can even see some of the genes that create these abnormal proteins that are coming from these diseases, right? So it's a fun graph. I think I stole this from Continuum. Oh, yep, Continuum right down here. So this is a wonderful graph, and you can see, right, for alpha-synuclein, we talked about dementia with Lewy bodies, Parkinson's disease, and they've also included Parkinson's disease dementia here, right? It's in this kind of orange square here. We have a beta amyloid plaque, so you have Alzheimer's dementia, Alzheimer's disease here. We have tau. We just have within that corticobasal degeneration and PSP, but you can see this green box contains other tauopathy. So you have behavioral frontotemporal dementia, right? Things like that. And it includes things like Alzheimer's disease. So this is a really great one to refer back to. So I've included that here, but we won't go too much more on it. The point of bringing this up, though, is that all of these tauopathies are sort of related to each other, which can make them hard to distinguish from one to another. Not even just Parkinson's disease, right? Parkinson's disease doesn't even have tau, but it's going to share some similar traits to these. So this is why it gets complicated, and it's nice to see these things over and over and get a sense of which one might be which, and then still be proven wrong on autopsy. So just to talk about progressive supranuclear palsy, PSP, it's pretty rare. The average symptom onset is around age 65, and then having it happen in young people starts to get vanishingly rare. So anything less than 40, pretty unlikely, and then maybe we're talking about a different disease. Anything that happens between around the ages of 40 and 55, really anything before 55 would be a more early or juvenile onset. And unlike with our alpha-synucleinopathies, where there's a male predominance, there's really no distinction between men and women with PSP. So for here, we can see, so what is tau? So tau is one of the normal proteins that we have in our microtubules. So as a horrible flashback to molecular biology from high school, or maybe college, whenever you learn this, right? The cell has a nucleus, it's got Golgi apparati and all sorts of things in it, but it's also got these like wispy chains of microtubules that go out, and then there's those proteins like dynein and kinesin or whatever they are that bring things to and from all along the microtubule. It's kind of like a monorail system, and we need tau to make those microtubules normal. But with these tauopathies, the tau is phosphorylized, it becomes abnormal. We can't make those microtubules, and then the cell dies because it can't transport all the things it needs. And some of the pathology or the histopathology we see from tauopathy like PSP is we'll see neurofibrillary tangles, which we don't just see in PSP. It's seen in things like Alzheimer's, dementia, right? And that's why it's not as specific. It gets more specific up here. But here's our neurofibrillary tangle under the microscope here. Then you can get these things called oligodendrocyte coils, and then astrocytic tufts are the most specific of these pathology findings. Okay. There are some gene mutations that we think are associated with PSP, with this microtubule binding protein up here, the microtubule associated protein tau, being the mutations there being the most, the strongest genetic links to PSP. So what does this person look like clinically? Well, they probably look Parkinsonian. They're going to be having some motor symptoms, but how do we distinguish? Well, with PSP, we used to just talk about something called classic PSP or Richardson syndrome. In 2017, there were new criteria created, and there are now 8 PSP variants. We still talk about Richardson syndrome or the classic PSP as the most likely cause, about 50% of all PSP cases, followed by PSP Parkinsonism, which is about 20%. Our next slide, we'll take a look at the 8 different subtypes, but we won't dwell too much on them. Usually when we're talking about PSP, we're talking about Richardson syndrome, that classic PSP. And with that classic PSP, people will lose the ability to have normal vertical gaze. And then they have slower amplitude or a reduction in horizontal saccades as well, so eye movements. And then, and again, this is sort of the key thing, they'll usually have these unprovoked falls, and it's very, very early in disease onset. So while falls are common in Parkinson's disease, with PSP, usually within the first year to 3, they're falling all the time, totally unprovoked, no mechanical falls, they're just dropping, usually backwards. That's less common for Parkinson's disease. Parkinson's disease, you get falls, but it tends to happen later in the disease course when they become more debilitated. So that should be a red flag to make you think, maybe this isn't Parkinson's disease if they're falling very early. Unlike alpha-synucleinopathies, you don't get the change in smell, no RBD, no REM sleep behavior disorder. And while you can get memory change, it's usually not that severe dementia that we think of with Parkinson's disease or dementia with Lewy bodies. These are those 8 subtypes. I know if you count this, you'll see that there's more listed. That's just because some of them are repeated. But again, I'm not going to dwell too much on this. This is really getting in the weeds. But if you're familiar with the concept of classic progressive supranuclear palsy, with that vertical gaze change and unprovoked falls, then you're thinking it along the right lines. Okay. So on exam, what happens? So like we said before, you get this vertical gaze palsy, so up and down. But interestingly, the oculocephalic reflex stays intact. So what is that? So if you were to hold somebody's head and move their head while they stay focused on you, as I'm doing this to me, my eyes stay looking straight ahead, even though my face is looking in a different direction. So that's an intact oculocephalic reflex, and same is true for vertical. And the reason for that is, since this is a supranuclear palsy, the nucleus that helps with those eye movements is spared. So even though the patient can't initiate vertical eye movements, you can induce them because the nucleus is spared. So that is a classic finding with PSP. If the eyes did not move, so if I were doing that and the eyes didn't move, the eyes would move with the head instead of looking straight ahead, right? So that's a loss. That would be a injury to the nucleus. So then we'd be thinking, maybe there's a lesion of something else, whether it's a stroke or Parinaud's phenomenon or something like that happening. You can still get cervical dystonia, but funny enough, it's usually the opposite of what you see in multiple system atrophy. And instead of anterior collis, the head brought forward, you get retrocollis with the head pulled backwards. Again, patients don't always follow the textbook, so these are just kind of loose guidelines to consider. You can get this kind of really soft kind of dysarthria where they're kind of growling, and it's really hard to understand them. You get something called the rocket sign, where when you ask somebody to stand up, they're sort of unaware of how unstable they are, and they shoot up out of their chair, and then they fall down. Something called the applause sign, which I have a video of towards the end, which we'll probably take a look at, but you ask the person, clap for me 3 times, and they go, and they just keep going, right? And then you go, no, like this, 1, 2, 3, and they go, oh, okay, and they go, right? They just can't stop. It's like disinhibition there, or uninhibited, I guess. Pseudobulbar affect, where people laugh or cry spontaneously, can happen. They can get some limb dyspraxia or apraxia, so motor planning is injured. They can get something called a positive pull test. I'll show you what that is in a little video, where you have the person stand, you stand behind them, you pull backwards on their shoulders, and they're supposed to, if they feel like they're falling, they're supposed to step back with their foot to catch themselves. Instead, they don't. They may take a bunch of short steps, and then they'll fall. Again, they're kind of uncoordinated. They'll just they'll plop themselves into a chair. They won't lower themselves carefully. You get this thing called the procerus sign, which is up on this woman here. So the procerus is that muscle that draws your brows together here. And it's kind of always going. So a lot of times these people are described as having a good poker face. Okay. Okay. So this is just that video of me trying to do the pull test. I'm going to do a little tug on your shoulders. Take a big step back if you need to keep your balance. Here we go. Okay, very good. Stand back up. Excellent. Can we try one more time? So you can see as I pull, he takes a lot of tiny little steps, and he would definitely fall if I didn't catch him. Okay. We'll do some neuroimaging, and then we'll move on to the last thing to talk about, which is corticobasal degeneration. For the neuroimaging here, if we look at this mid-sagittal cut, you get something called the hummingbird sign, where now you can see the pons is pretty plump, but the midbrain up here is shrunken, and it looks a little bit like a hummingbird, which I have here. So right up here, this is a normal midbrain. You can see it's much more plump. Over here, it's shrunken and atrophied. Sometimes it's called the penguin sign. I've never called it that. On an axial cut, you can get the morning glory sign, again, shrinking of the midbrain, or the Mickey Mouse sign here. Same kind of idea. Again, prognosis is poor. Usually people die within about 7.5 years of being diagnosed of classic PSP versus the one where we said only about 20% of people have it, the PSP with Parkinsonism. So that's about 10 years. But again, it's variable. It's different for each person. But again, prognosis is poor. This is a condition that leads to death. We're going to finish with talking about corticobasal degeneration, CBD for short. More broadly, we talk about corticobasal syndrome, or CBS, and that's because people can look like they have corticobasal degeneration, but it may not be corticobasal degeneration causing it. There are other diseases that have similar appearances. Even Alzheimer's disease can cause corticobasal syndrome. So it's much less common than PSP. Again, it happens in older adults and very rare to happen in somebody under the age of 45. Corticobasal degeneration has these hyperphosphorylated 4-repeat tau inclusion. So again, it's a tauopathy. You can get these different changes to some of the glial cells. They develop these things called astrocytic plaques, whereas the PSP had those tufted astrocytes. So this is something that we'd see after a patient has died. Okay. The genetics, again, are similar to PSP because we're talking about abnormal tau. And again, these corticobasal syndrome, about 50% of the cases are from corticobasal degeneration. That's the disease versus the syndrome. Other things can cause corticobasal syndrome, including PSP. Again, a lot of overlap, or Alzheimer's disease. Again, these are all tauopathy, so it makes sense that they can cause similar symptoms. There's different ways that we break this down, or how we describe it. And really what we're talking about with corticobasal syndrome or corticobasal disease, corticobasal degeneration, you usually get rigidity or a total loss of movement in one limb, like an arm. And it can even have something called alien limb phenomena, where it moves kind of on its own. The patient isn't aware of it. It does kind of its own thing. And the patient really doesn't have control over it. They'll get a dystonic limb, right? Twisting or pulling of a limb. They can get jerky, myoclonic movements, and they often get limb apraxia. This is, again, kind of breaking down corticobasal syndrome into different subtypes. I'm not really going to dwell on this. More interestingly are the exam findings. So in addition to the alien limb phenomenon, which I talked about, where one limb just does its own thing, classically people like to show Dr. Strangelove. The character has like the bizarre arm movements. That's the example most people do, but I'm sparing you that. You can get apraxia, right? Poor motor planning. So asking somebody to comb their hair or cut a piece of bread with a knife, they'll have a lot of difficulty planning that, and they may not be able to do it. There's something called agraphesthesia, where you have them close their eyes and you say, I'm going to draw something on your hand, and you can say, okay, I'm drawing a number. What number is this? And I drew the number 3. They should be able to feel it and say 3, but they may say, I have no idea. Or I could do the number 4. They won't be able to feel it. Asteriagnosis, so that's where you have them close their eyes. You put an item in their hand, and they're supposed to be able to feel what it is and say, oh, this is a key or a paper clip or a pen, but they won't be able to. Neuroimaging, you get a lot of atrophy, usually in the frontoparietal lobes. It's usually asymmetric because one limb is more affected than the other. So you can see pretty significant atrophy. This one looks like it's more back here on the right. Again, very poor prognosis. These are all patients who are dying usually within 10 years of symptom onset. And again, dysphagia, difficulty swallowing, or aspiration are common causes of death. I only have a few minutes left. I'll show you maybe some highlights from this video of a real patient. This was not one of mine.
Take the right hand and open and close.
He's asking him to open and close his right hand, and you can see that the left hand is much more affected. It's actually one of my mentors who did this. So it's a lot slower. So some bradykinesia. He is trying to cut a piece of bread, and instead he's chopping his hand off. So that's some apraxia there. He does okay when asked to comb his hair here with his left hand. Yeah, a little bit better there. Not great. Again, trying to cut bread, but we'll move on. So he's asked to hold up 2 fingers, and he can't here. He's really struggling to hold up just 2 fingers. He's asked to do a thumbs up. He has an easier time doing a thumbs up. Here, he's asked to draw the letter Z with his left foot. It's a nice smear on the ground, like he's stomping out a bug, but not the letter Z. So a lot of poor motor planning there. So that's apraxia. Okay. So this is the applause sign. He's asked to clap 3 times. It's 5 claps.
So tricky, huh? 3 times.
3 times. 1, 2, 3. 5 claps every time.
I think the snaps took it.
He's got slow eye movements. And look at him walk. That right arm is a little bit more normal. That left one is held kind of postured up. It doesn't really swing much. So that's a very affected limb, right? He is not volitionally doing that. Even just holding the arms up and trying to turn them side to side, you can see he's really struggling to move that left limb. When we look at his imaging, right, the right side is significantly more atrophied, which makes sense because it's the side that affects the left limb. Okay. This is his DAT scan. A little bit hard to see, and I'm sorry it's small, but when you look here, you can see that it's more robust and bright on the left and a little bit dimmer on the right here. Again, he's losing dopamine on the right side, which is causing those motor symptoms on the left side. Okay. Management for PSP and corticobasal degeneration, very similar to what we've been talking about. It's mostly symptomatic management. Carbidopa-levodopa usually does not help with these conditions, unfortunately. Sometimes it can help with the Parkinson's type of progressive supranuclear palsy, but not always. For things like pseudobulbar affect, which we mentioned before, you can try things like dextromethorphan and quinidine. For mood in general, you can try SSRIs. But again, we're doing physical therapy, occupational therapy, speech therapy, botulinum toxin injections for things like that dystonia or spasticity. We do not offer neurosurgical intervention. And again, like I said, PT, OT, and speech. I just want to give acknowledgments to the people who helped me with this. The Wyants here, and these are several of my mentors, including Dr. Adam here, who you may have heard speaking in that last video. That was one of his patients. Not featured is, of course, Dr. Mulho. I wanted to know if you had any questions. Sorry, I really brought us close to time. I'm pulling up questions here. Okay, let me, I have one question here, which I can address, and then I think Dr. Wyant was going to ask something. So a question here, as a primary care provider, how much should I do for a patient with suspected Parkinson's disease prior to them being seen by a neurologist? Sometimes the wait can be extensive in the area. True for all areas is what I found. I usually get an MRI brain and try them on carbidopa-levodopa. I have gotten a DAT scan before. Okay. Great question. I think what you're describing is if you have a suspicion for Parkinson's disease, it's never a bad idea to try carbidopa-levodopa. I usually recommend starting with something like the 25-100 immediate release tablet and slowly titrating it up over about 6 weeks that the person's taking 3 tablets a day. So 1 in the morning, 1 in the afternoon, 1 at night. For something like that, I usually start with half a tablet in the morning for a week. Then on week 2, half a tablet in the morning and the afternoon for a week. Week 3, half in the morning, afternoon, and evening. Week 4, full tablet in the morning, half. Week 5, full, half, and then 1 tablet 3 times a day. That's a really great place to start. Physical therapy, always a great idea. There's usually exercise programs, things like rock steady boxing, which is like a no-contact exercise program for Parkinson's disease, walking, running, stationary bicycle, some kind of aerobic exercise is usually critical for helping slow down the rate of disease progression in Parkinson's disease. So if you're able to do that, that's a great start. It's never terrible to order a DAT scan, but there are certain medicines that need to be stopped before you can do it. Most of them are the SSRIs, and there are a few others as well. So if you're going to order it, you definitely want to make sure that the person's not taking one of those medicines, because if they are, the results won't mean anything. So, and it can be an expensive and long test to do just to be told that it wasn't worth it. So, yes. Thank you. Can you comment on another question? Can you comment on CSF and plasma biomarkers, such as DDC and alpha-synuclein seed assays, and combining CSF, DDC, and alpha-synuclein seed assays, both for diagnostic and prognostic purposes? Good question. So I'll be honest, I have not done any CSF trials myself. This is still something that is coming along, and the goal is to get something for tau. In truth, when I usually do not use those biomarkers for atypical Parkinsonism, we sometimes use some of these biomarkers for Alzheimer's disease, especially if we want to try one of those newer infusions like lecanemab or donanemab, which are Leqembi and Kisunla respectively. That's a little bit outside of our scope now, but in terms of alpha-synuclein, usually I'm doing something like that SYN1 skin biopsy instead. You are right, there was something like brand new within the past, I think, 2 to 3 months about CSF studies looking at risk factors with things like alpha-synuclein. And to be honest, I'm not even sure how to interpret those yet. So I don't think I could confidently give you an answer because they're so new. So I haven't used them yet. But it's a really good question. I think Dr. Wyatt.
I didn't have a question, but I did want to say thank you very much for giving this presentation. Extremely thorough and fascinating, at least to me, and I think incredibly informative. So I really want to say thank you to you on behalf of Centera and EVMS and ODU. I also want to say thank you to everyone in the audience for asking good questions, giving your attention, because I think that this is a particularly useful review that we just received.
Thank you, Dr. Wyatt. I know that we're basically at the bottom top of the hour, one of those. But if there's any other questions, please feel free to send a message. Like I said, I think I have given the PDF version of the PowerPoint out. It's a big file, so we weren't able to do it as the slideshow itself. So I don't think the videos will work on that, but feel free to take a look at that. And thank you for all the nice thank yous. You're welcome. I'm glad I was invited out to talk to you all.